to have two of Georgia's, and really I think the Southeast finest statesmen here with us today to bring us the legislative update. They are very well known, both of these gentlemen, to anybody who follows Georgia politics and Georgia legislation, and I'm a little bit embarrassed to even give them any introduction, but there are quite a few of y'all here that have come from far away, so I'll give you a brief introduction. I'm going to start with Terry England, who's on the far end here. I asked Terry, how should I call you Mr. Chairman, or how should I call you? And he said, just call me Terry. And I think that's a great way of knowing what Terry is all about. Terry has been in the General Assembly as a representative since 2005. In 2013, he stopped representing the 108th district and started representing the 116th district, which is Barrow County, which is right down the road from Athens. When I asked him if he needed a room, because we put some of our speakers up for a room, he said, no, I'll just drive over. So, Terry, we're so glad you're here with us. He's a lifelong Georgian. He went right here to University of Georgia school, and he is an agribusinessman and a farmer. It is fair to say that many people, and me especially, thinks that Terry is probably behind Governor Deal, maybe the Speaker of the House, arguably the most important person because he holds the purse strings. He's been chairman of the House Appropriations Committee, which includes, importantly, the subcommittee for that committee for health care. So a lot of the dollars, those of you who want to raise your hand and tell Terry you'd like to pay more taxes so he can have more money to spend on health care, please see him. He'd like to know and meet all of you who want to pay more taxes to pay for health care. We're just very fortunate to have him with us, and he's become, as I learned when I was talking to him, an expert in health care. He'll deny it, but he is. Next to me is Senator Dean Burke. He is a Republican as well and represents the Georgia Senate District 11. He represents several of the counties down in the southeasternmost corner of the big state of Georgia. And Dr. Burks has been in the Senate only since 2013, but he's chairman of the Ethics Committee, vice chairman of Health and Human Services. I think maybe on the Healthcare Subcommittee Appropriations, you're either chair. It's because he knows a little something about that part of the state he represents. He knows a little something about healthcare. He's been an OBGYN throughout his career. He's the chief medical officer of Memorial Hospital in Decatur, Georgia. And what we're going to do today is let each of our representatives give a 5-minute, or as long as they want, a little overview of their perspective of the last session of the General Assembly, which just wrapped up 3 weeks ago, and sort of give us each of them their perspective, and then we'll, after hearing what they're thinking, keeping them up at night or making them feel pretty proud about what they accomplished, we'll have some conversation. So maybe start with you, Senator Burke.
Thank you, Bill. First of all, appreciate the work you've done to establish this meeting for its second year. You've got a lot of thought leaders in the room, and it's very valuable use of my time. I feel like I've got a little bit of an edge over Terry in that I make my living in healthcare, and coming to meetings like this, I get credit for at home, at work, and with my Senate hat. And for somebody that's an agribusinessman to have the respect that he does in the healthcare arena just shows you what kind of person he is and how smart he is. Well, I don't know about the smart part, because being in the representative in the state of Georgia is not real bright. Absolutely. The representatives, like to kid the Senate, they get the same amount of pay, and they only have a third of the amount of people they have to represent. So they claim to be a whole lot brighter than we are in the Senate, and I'm not going to argue with that point, because I've got 8 counties in southwest Georgia, and my district is bigger than a lot of congressional districts in Georgia, and so there's a lot of territory to cover. And but it's fun. I wouldn't do it if it wasn't. As far as the session, I thought it was a productive session. We're kind of getting into what I call the silly season of elections for 2018, and that's an undercurrent that we have to deal with every day at the Capitol, is people posturing and trying to put themselves in the best light, and sometimes that brings out the worst in partisan politics, but that's just the reality we live in every day, and it comes with the territory. Obviously, I ran for office because of the healthcare issues and wanting to be a part of the solution rather than just bitching about it, which most physicians like me, that's what we do every day, is complain about all the regulations and issues, some of the things that y'all have heard here today. And unfortunately, the physicians of the world tend to keep their head buried in the sand and want to do their job every day, but don't realize how many of the decisions are being made by people that don't know a damn thing about health care. And they've got to get involved, and that's one of the things that I preach when I speak to the medical community. And there are a few docs in the room, so that those that are here obviously get it, but unfortunately not many do. Focusing on specific legislation, Terry and I and several of our colleagues have been championing the tax credit for rural hospitals. We did some what I call improvements, modifications this year to increase the percentage from 70 to 90%, and I think that will greatly help the uptake, the number of people that participate in it, just because it makes more financial sense. It's easier for the CPAs of the world to sell a tax credit that, when you combine the federal and the state tax credit, it's basically a good financial decision as well as philanthropic. And as much as we appreciate people's philanthropic efforts, we didn't think that was going to be enough. So we had to sweeten the pot a little bit. We also passed another bill that allows for the state to establish grant programs, so kind of have a backup opportunity to funnel some money into the rural hospitals system as we try to navigate what's going on in this really challenging world we're in. You're going to hear a little bit later about some of the balanced billing issues that did not pass, but I think a lot of progress was made as far as education of our members of that importance of that subject, and I'm fairly certain something will happen there in the next year or two. Politics is a long game. Some people think that they can come in and get something done right away, but usually they're frustrated and impatient, and those folks end up leaving because it's just not the way it works, and it shouldn't be easy to pass laws. Certainly, budget-wise, Terry and my chairman of the appropriations, Jack Hill, both represent rural areas, and we're very lucky when we're talking about rural health care that they have that background. It's easy in a state that's dominated by the metro Atlanta area to not have rural people in those important positions, and I think we're just very lucky right now to have people that understand the difference between metro and rural Georgia, and I want to thank him publicly for all the hard work he does in that role. Being chairman of appropriations is a extremely difficult job because everybody wants money. We don't have a money tray. Hard decisions have to be made, and I can promise you, I'm only on that subcommittee on health care, but every day there are people coming into my office with needs, and every one of them just breaks your heart as how much sense it makes and how much it would be great for me to say, yeah, let's help you. But you've got to have a balanced budget in Georgia, and we don't have the resources to make everybody happy, so we end up having to make tough calls. And you end up making a lot of people mad too. So that's another part of this business that we have to deal with. But my focus is in the future is just on trying to to find a solution to rural healthcare crisis, both on the fiscal side and financial side, but even more importantly as a physician is on the quality of our care that our patients get. And I applaud Dr. Nelson's group for what they're trying to do. I made the question earlier that if we fix the fiscal side and we stabilize rural hospitals, we really are probably only a third of the way, because so many of our healthcare problems are related to poverty and cultural issues, bad habits that our patients have, and those the addiction issue. I mean, all of those issues are extremely complex, and they are not going to be solved by anything but hard work and people working together and trying new things. If it was an easy problem, we would have fixed it already. And so I just applaud what he's doing, because I do think that's the kind of efforts that we're going to need to make a difference. And I'll one more point, and I'm going to shut up. The piece about the scientifically monitoring the work that they do and making sure that when they say this is working, that it really is working, helps us so much to be able to say, okay, that's a wise use of our dollars. And that's one of the things that I keep harping on is, if you come to me with an ask for money, you need to know that money is going to work, that whatever the effort is that you're trying to do is got some data to show it's successful, rather than just your dream or your wish. I love those too, but we can't afford to fund all of those.
Great, Terry.
Well, good afternoon. Everybody's got their mouths full. Okay, that's all right. That means you're concentrating on eating instead of so much of what me and Dr. Burke are saying. Bill, thank you for putting this on. Thank you for asking me to be here, and thank each of you for coming, because obviously this is maybe one of the most important topics in the state today is what are we doing in rural Georgia and rural health care, and what is the sustainability of that. And when I came into my role as the House Chief Appropriator, as Chairman of the Appropriations Committee, my weakest link, and some would argue it still is among my weakest links, but was dealing with health care, because when I was elected 13 years ago and going to the House, my practical knowledge, of course, was dealing with agriculture. That's what I did. That's my vocation, that's my avocation, it's my hobby, and it's my living too. And so that was my focus. And the things that surround agriculture in this state were my focus. Well, as I stepped into this role 7 years ago now, I realized, and I started realizing before that healthcare is an important piece of a healthy agricultural economy in the state as well. Education, workforce development, infrastructure, so many things, but a lot of it deals with healthcare and the availability and access to healthcare in rural Georgia. You look at a community that loses a hospital or doesn't have access to a hospital. You look at a community that not much longer will be in existence, or if it is, it will be in existence in a very different manner than what it is today. Because when we look at communities that wind up losing hospitals, you wind up basically killing off their ability for economic development. And so over the last 5 or 6 years, I've tried to visit, and I've been in some of your hospitals over the last 5 or 6 years, and probably 15 or 20 of them at this point, and just kind of doing a real quick run through of what your issues were while we're there. And out of that, a couple of years ago, came the Rural Hospital Stabilization Committee and the work that it's been doing. Some of our folks from the Office of Rural Health were here earlier, talking a little bit about it. And we're excited what we've learned there and the way that we've been rolling it out. We're now with, we had 4 pilot hospitals year before last. We had 3 hospitals last year and this year. And then with what we did in the budget this year, there will be 12 hospitals that now will take a lot of what has been learned in the 7 pilots and be put into place in those 12. one of the things that became obvious to me as we were going around talking to different hospitals and individuals was that you guys, you folks and ladies that run these hospitals, you're focused on running a hospital. And earlier this morning, folks were mentioning about 2 days cash on hand and how you're going to make payroll on Friday and those kind of things. And those are true issues. You don't really have a chance at that point to really think outside the box and think about doing other things that might improve your life, because you're focused on what you should be focused on, and that's making sure that you're taking care of your employees and your patients there. And you really don't have that luxury of being able to step back a little bit and say, okay, we need to be doing this and this, and we need to be talking to this group, or we need to be talking to that group. So one of the things that kind of came out of the first group of pilot hospitals right off the bat was getting all of the interested parties in the room and sitting down and everybody communicating with each other. And, Courtney's sitting here on the second row, and their hospital down that way, he's fortunate that they have a good line of communication with their hospital. But that's not, believe it or not, EMS communicating with hospitals is not something that's statewide. Community service boards, because mental health, of course, is a huge issue in rural hospitals. Community service boards in the hospitals were not talking. The FQHCs in the hospitals were not talking. Even some of the physicians within the hospitals were not talking to the hospitals. And so it's a matter of getting those individuals in the room. And when we look back on what we've done through the Rural Hospital Stabilization Committee, if we can make that the accepted practice throughout the hospital community statewide, I feel like that we've accomplished an awful lot. We may not have anything else to show, but we are going to have several other things to show from it. But that alone is one of the major things I feel like comes out of that. We're fortunate to have Dr. Burke up there now. We've had doctors in the House, and we've had doctors in the Senate, but usually the doctors come from larger metropolitan areas. And as y'all know, doctors practicing in rural areas, it's hard for them to walk away from a practice for 3 months to come to Atlanta to sit there and try to take care of rural issues. Dr. Burke is in a unique position with his hospital to be able to come up there, and I know it's not easy for him, it's not easy for any of us being there, but especially him, but to bring his perspective as a practitioner and as someone that's kind of in leadership of their hospital too. So it's been good to have someone on that side of the building kind of fighting the same battle that we've been fighting for a little while on the House side as well. But kind of spinning off of the Rural Hospital Stabilization Committee is this year the Speaker has developed a Rural Development Initiative, a Rural Development Council. And fortunately, I get to serve as one of the co-chairs on that, and as well as one of my colleagues, Jay Powell, as chairman of the Ways and Means Committee from down at Camilla. And I'm excited about what we're going to do there. Rural health care is going to be a tremendous focus of what we're doing, but we're going to be looking at some of those other issues that I mentioned earlier, education, infrastructure. And it's coming to, we've heard it, we've talked about it, but we're starting to realize that broadband connectivity across the state is a huge issue. We take it for granted. I take it for granted living in Barrow County. When I grew up in Barrow County, it was rural. It's not now. I wish it still was a lot of times, most of the time. But we take it for granted a lot of times when we're close to Athens, we're close to Gainesville, we're close to Atlanta. We take it for granted what a lot of the state does not have, the access to so many things that the rest of the state does not have. And so I think, that it's kind of shaping up. We're getting ready to start our meetings in May, and it's kind of shaping up that broadband is probably going to be one of the biggest issues, because while it alone is an issue in itself, it goes into so many different areas. Y'all have talked a little bit about electronic medical records today, and the ability to send those records, the ability for an ambulance with a 15-lead EKG having Wi-Fi connectivity, so when they're at an accident scene or they're at a heart attack scene, they can hook somebody up and do an EKG and transmit it via telemedicine to an emergency room somewhere and know what to do for that patient while they're in the back of that ambulance. instead of having to wait till that ambulance gets to the ER to start treatment. So there's so many things that are tied around that as a hub, I think. But I'm looking forward to that work. And you mentioned my district numbers had changed. I never moved. It was through redistricting that the numbers changed. And so I've always been in the same spot. Grew up on the farm that was my great-great-grandfather's when he came home from the war between the states. And we've been there ever since. But, I love my state. I love our state. And I want to see what we can do to help all 10+ million citizens that live in this state do the best that they can, to have the best access to health care, have the best access to education, have the best access to jobs, transportation, anything that their hearts desire. As these kids are graduating from this institution and 29 others across this state, that they've got a pipeline that they can go into to get a good job. When we look at 30+ technical colleges across the state, as they graduate from them, that they've got a place to go get a job, and that we're doing what we need to be doing from the state's perspective to help business do what it needs to do from a capital perspective.
Thank you. Great overview from both of you. I'd like to ask 2 or 3 questions and then see where it goes. And feel free to ask each other questions. I'm sure you didn't get enough of each other during the General Assembly. You probably, what the hell were you thinking, Terry? Or what? There are probably some questions like that. Does it? Okay. So I'm really proud also to be a Georgian and a law dog, graduated school here. And, we often forget that some of our biggest challenges come from some of our greatest blessings. We are very blessed in Georgia to have a great big old Atlanta and a very big and diverse, geographically speaking, state. And what works in Atlanta doesn't work down in Bainbridge necessarily, probably usually doesn't. But there are a few things that every part of the state share, and mainly it's as bad as access is to health care, and particularly specialists and other providers in the rural area. It's tough in the cities too. And I know y'all did some really important work about the physician access, particularly in the rural areas, supporting Morehouse, Mercer, and others. Terry, Dr. Burke, would you like to talk about this program? Very exciting about the new fellowships and support in that area.
Well, we did this year. I think there are 97 new residency slots that the state is funding. We're kind of in a pickle in Georgia that the federal government allocates slots to states, and we have far exceeded our slot allotment of where the federal government reimburses hospitals and other entities to be host to residents. And as we begin to realize the shortage that we're looking at 20 and 25 years out, even 5 years out for that matter, we realize that, that allotment's probably not going to change anytime soon, so we need to do something ourselves. So we added 97 new residency slots. Our partnership with Mercer and Morehouse, their focus is to focus on putting docs in rural and underserved areas. MCG, of course, does a great job on doing all kind of docs, whether specialties or general practitioners or whatever. But a lot of the kids that go to MCG have a focus on what they're going to do, and so a lot of times the students that wind up at Mercer and Morehouse, I was about to merge them right there. I don't know what that would look like, but anyway, it'd be spread all over the place. But with the partnership the state has with them is to focus on rural and underserved areas. And as me and you had a conversation on the phone the other day, an underserved area rural areas are underserved, but then we have that same issue when you get into the heart of Atlanta, when you get into the heart of Macon, you get in the heart of Columbus, you get in the heart of Savannah and some of the other big cities around the state, that you may not, while you just take it for granted that you're going to have access, you may not have access. Large populations may not have access. So, that's that concentration there, and we're excited about Mercer and Coliseum Medical Center there in Macon. Announced a major new residency program down there last year, and so I think they're adding 300 slots over the next 2 or 3 years. And so that's what it's going to take, because we know that if a student does their residency in a rural area, there's about an 80 or 85% chance that they're going to stay, not necessarily where they did their residency, but they're going to locate to a rural area because they enjoy the quality of life. And so that's really something that we've really focused on. The governor is focused on. Actually, the governor actually kind of took the lead on this about 4 years ago and trying to make that focus. And I think it's critically important.
I would certainly echo that. The only caveat that I'm a little bit concerned about is there have been people to say, well, maybe we're there, maybe we're close to where we need to be on the residency side. And if you look in Metro Atlanta and even Northeast Georgia, the number of residents there now, I think probably is adequate. But if you look below I-20 and certainly below I-16, that's certainly not the case. And when you draw those 90-mile radiuses around residency programs, there's a lot of my territory that's outside those circles. And so while I think we need to evaluate that spend on graduate medical education extremely carefully, I don't want us to throw the baby out with the bathwater, and we do probably need additional funding for more slots. The rural hospitals that have to host those are the ones that are in trouble, and they're the ones that are most hesitant to take on that long-term burden of carrying a residency program. There's several very successful hospital systems in South Georgia that would love to have a residency program, but they're just scared to make that obligation because of the uncertainties that we have. And so we've got to figure out a way to kind of settle their nerves and let them know that they will get the support they need. Because, again, if we're going to have professionals in our area, we're going to have to train them in our area. I don't think we can afford to pay them double to come down here when they, because that's what it takes. And those folks that are coming down because we're paying so much, because they have so much medical debt, they see that, okay, this is a way to pay back my loans. Those people tend not to stay. I mean, as soon as they get their loans paid for, they go back to the city. So it is a long-term issue that we're still struggling with.
While we're talking about improving access, there are two other areas that comes up almost anytime you talk about access, and you alluded to the expansion of broadband and trying to address that issue. And so telehealth, we have Reach Health, who was started out at MCG as one of the programs doing Telestroke and is now all over the country. And Steve McGraw's here is going to be on our telehealth panel. Do you see, in terms of telehealth, and this is to both of you, do you see telehealth and maybe readdressing or looking at how we use physician extenders, either supporting the growth of those practitioners or maybe looking at what are things for you, Dr. Burke? I know that's always been among physicians, and in your clinical, ethical, other areas, we would like to have more caregivers, but how do where's the proper drawing of that line? So are either of those issues, extending access, something that you're looking at?
Well, in my day job, we've already instituted a telestroke initiative in our hospital. We're about to initiate a telenephrology. Dr. Cantos brought that idea to me and talked to the folks at Swainsboro about that, and so we're actually really close to beginning that program in our facility, and that does two things. It allows us to keep people in the hospital close to home, because so many of our patients don't have the ability for their families to drive 60 miles to Albany or Valdosta or Thomasville or whatever to follow their family member that gets moved. But as many of the earlier folks from the rural hospital said, our outcomes are damn good, and so if we can keep them home, close to their family, and have good quality clinical outcomes, and that helps the bottom line of that rural hospital. I mean, that's a win-win-win-win. And so, but that's going to take the technology. The broadband obviously is important. state support, encouragement, incentives to develop these software programs for us to be able to crunch the big data that was discussed earlier today. I think that is going to be one of the secret sauces to improving our health outcomes. Dr. Nelson and I have talked about that many times. There are programs out there that gives rural doctors a great picture of how good they're practicing medicine and which patients need what. But right now, most of them can't afford it. It's just cost prohibitive, and we've got to figure out a way to incentivize that from the standpoint of making all those primary care physicians feel like that's something that they can implement.
Well, you mentioned physician extenders. That was one of our preliminary reports from the Rural Hospital Stabilization Commission was expanding the role that they can play, because one doctor can see X number of people in X amount of time, and if you are the sole doctor, sole practitioner in a particular area, and you can see 20 people in a day, but there's 100 people needing to get in to see you, then that's 80 folks that are not going to be seen, and the condition just continues to worsen. So that was one of the things that we talked about out of it. We've made some headway in the legislative process in changing that. We're probably still not where we need to be. A good bit of headwind every time we go to talking about that. Telemedicine, the future for telemedicine in rural areas, urban areas, suburban areas is amazing to me, especially when we go to looking at telemedicine in schools. You think about a child getting sick at a school, goes to the front office, and I need to call mama, come get me and take me to the doctor. Well, the parent has to take off from work, come get them, take them to the doctor, take them to the drugstore, then probably go stay with them at home, or bring them back to the school if it winds up it's nothing contagious. Well, that becomes, to a family that's struggling, that is a big deal when someone's having to take off from work to go do that. So one of our first pilot hospitals, Appling, was one of the first hospitals to actually start putting telehealth into their local schools. And so what we started seeing there was not only the students, but the teachers and others that are there with the school, especially those that are on state health benefit plan, were able to go and access telehealth right there, not have to take time off. Students sick, go there, telemedicine, see a doc. Okay, you got an ear infection, but you're not contagious, you can stay or whatever, unless you just get feeling so bad. But those are the kind of things that I think telemedicine, we're just kind of on the very edge of seeing. Doc mentioned the stroke program, and you mentioned the stroke program and everything. Those are truly game changers in rural hospitals that do not have the specialists there to take care of those kind of things. But taking it a step further to getting it out into the public, getting telemedicine out into the public, putting at check some of the conditions that if allowed to go another 2 or 3 days would be a lot worse, and nipping it in the bud at that point, it has a huge economic impact on families that can't afford to have a huge economic impact.
Last question, and we can open it up to the audience. It comes up. I know you never go anywhere to talk about health care in Georgia and not get the question of what can we do with our Medicaid? How can we bring some federal dollars in and try to increase that level of support? And I know everybody's been scratching their head thinking about it, so I'll just put the question to you pretty directly. Do you see maybe in the coming year with the new administration, with our own Georgia Representative Tom Price now, and in HHS, some new opportunities that would allow you to keep the same principles that you've been in terms of balanced budget and the other principles that have been very good for our state, and yet to find a way to find some new Medicaid dollars? And I'm not looking at either of you in particular, but that issue's already come up earlier with a couple of different panels, and I think it's always on everybody's mind. Is there a way to skin this cat that allows us to remain principled, but also, if possible, get some additional dollars out into the rural hospitals for Medicaid?
He's looking at me. Uh, and I've not been a politician as long as he is, so I'm stupid enough to open my mouth here. I think the opportunity now to design a Medicaid program that would fit the state of Georgia is present, that we haven't had for the last 8 years because of the partisan politics that I wish I could say we're going to try to get behind, but I'm not that optimistic about it on the federal level. But in my mind, there's several issues that are wrong with our current Medicaid program, and this is not anybody's fault. It's just the way things develop over time, and governors all have their focuses, and this current governor's focus has been on education and criminal justice reform, and our state has benefited hugely from those things. We're a lot better off than we would have been without them. But the focus on health care and being kind of on the cutting edge has not been there. And some of that is because, of the handcuffs that the feds have placed on us. Anything innovative that we wanted to pitch to them was automatically, turned down because they wanted us to expand Medicaid. And so there was that push-pull going on. And I think that's just, again, that's unfortunate, but it's the way it is. But I think now that landscape has changed, and I think there is an appetite to try to figure out what would work for Georgia. I think our ABD population that is not under managed care, I think the opportunities there to improve those outcomes with integrating mental health and behavioral disabilities and the aging population on the physical health side to integrate those programs and develop some quality pilots is a great opportunity. That ABD cost is exploding, and our outcomes are not as good as they could be, and I think that's very unfortunate. And again, we're just going to have to design a Georgia program that we can get through the legislature, which is not an easy thing to do. But I do think there is an appetite for some development of some waivers this year that will be unique, that Georgia's never had before. And I'm optimistic 10 years from now, I think we'll be in a very, very good place, but it's going to be very painful in the meantime, and we're going to have some folks screaming and some folks that feel good about it.
Doc said it best, I think, in the very beginning of having a program that works for the state. Right now, Medicaid is basically one size fits all. And so you look at Georgia, you look at Washington State, you look at Maine, you look at Hawaii, the populations have distinct differences. You look at us in Georgia, we like to eat, so of course we're going to have issues with heart and stroke and those kind of things. And so each place you go to, you're going to have those differences. And unfortunately, the way Medicaid is right now, as y'all know better than I do, there's very little flexibility within it to take advantage or take advantage of new technologies, new methodology, or whatever. But there is also, from the state's perspective, very little ability to custom fit for a lot of the things that we need to be doing. And so, and whatever winds up, the chemistry winds up being that makes us really consider looking at Medicaid expansion. I think you've got to have the flexibility that the states can do what they need to do to best serve their population. I think the states need to have the assurance that if we go into this, we got 1.8 million folks on the Medicaid rolls right now, we do whatever we're going to do and wind up with 2.3 million tomorrow on the rolls, that we're not locked in at the funding level of 1.8 million. That, Georgia's been very fortunate. We were incredibly fortunate during the recession in a lot of ways. We didn't go nearly as deeply into the recession as a lot of other states did. But the one thing that amazed me was during that whole period of time, the amount of people that were moving to Georgia with hope of finding a job and the hope that Georgia would turn around quicker than other places did. So we had a lot of folks move out of the Rust Belt. We had a lot of folks move out of the Northeast. to come down here with the hopes of finding jobs. Well, that migration is going to continue. If we don't have the flexibility to deal with that, then it's pretty much a no-go for us. The other thing becomes the assurances long-term that whatever the federal participation is going to be, that it remains there. Because if you know, I've heard different figures, but if we're looking at $1.5 billion new dollars coming in, and we expand to take up that $1.5 billion, and all of a sudden 2 years later the feds come in and say, well, we're not going to do that anymore, what are we then going to do? I'm always mindful of, I get hit with the argument a lot of times about, well, you know, we're sending all this money up to DC, but we don't get all that we send back. Well, it's kind of my job to look at that. And one of the things I look at fairly often is what is our return on $1 sent to DC? What are we getting back in Georgia? And over the last 7 or 8 years, we've been somewhere between 99 cents and $1 and a penny. So for every dollar we send up, now it may not necessarily be in transportation, it may not come back in the form that we send it up, but when you look at it in total, we're very, very close to dollar for dollar getting it back. And I would go further to argue that anytime you transact money, there's overhead cost involved with that. So we're probably getting more back than what we actually should be getting. So you carry that argument a step further, and when you look at another $1 billion or $1.5 billion coming into the state, that means the federal deficit then is going to grow as well. And my colleagues in the House and Doc's colleagues in the Senate, we're very mindful of that for not only for ourselves, but for our children and our grandchildren in the future, and what the country will look like, what the national deficit will look like. And we don't want to be ones labeled of being ones that added to that additional burden for 2 or 3 or 4 generations on out. So that's something that we're very mindful of as well. You know, I think when you look at that issue, it's going to bubble out somehow. But we're here talking about rural health care. One of the things that's very important in rural health care in the state of Georgia, and I might be getting off topic a little bit, but I know there's a lot of focus on Medicaid expansion, but the battle that Doc and I see developing, I think, I may be speaking out of turn for him, but is dealing with certificate of need. And we know that for rural hospitals, CON is incredibly important, because if someone comes in and takes the cream off the top for providing procedures, and you're left with Medicaid patients or no-pay patients, you sink pretty quick. And it's becoming harder and harder for us to convince our colleagues in Atlanta that CON is necessary when you get out to our parts of the state. So I think over the next year or two, that is going to become a bigger and bigger and bigger discussion, and one that's going to be harder for us to fight. And I would kind of encourage those of you here to, when you're talking to our colleagues back in your home areas, that you mention that. And, you know, does it wind up becoming a separation? I know Senate Bill 180 that Doc had mentioned a minute ago, and Senate Bill 14 that we did with the tax credits and the grant program. We've changed the definition of rural areas up to 50,000 from 35,000. Picked up, 5 or 6 hospitals, I think.
7 or 8, I think.
7 or 8. Anyway, you know, that might be the dividing line. And that might be where the discussion needs to go, is saying, okay, if you're above 50,000 as of whatever census, then if you're below that, you're still protected by CON. If you're above that, then that discussion may be different. But I truly think that needs to be one of the focuses of those of us looking out for rural health care.
That's a great topic. We have a policy panel. I hope that issue will come up this afternoon. Fazil, do we have time for a question or two, or do we need to wrap it up? One question. Okay, one question in the back.
Well, I referred to that a few minutes ago as one of the findings out of the Rural Hospital Stabilization Committee, and you were right. That is something, and Doc and I, this year we actually had a bill that would have expanded scope of practice a little bit, and it got bogged down pretty bad. We still find a significant amount of resistance as we try to move forward with that among our colleagues. And one of the things that I hope we're able to do through the Speaker's Initiative on rural development is kind of bring it even more into the forefront of helping our colleagues from the urban areas understand that, okay, that may not be an issue for you, but it's a big issue for us out here. And so politics moves fairly slow. Our governing moves fairly slow, and it gets frustrating from time to time. And that is a prime example of one of the things that a lot of times gets bogged down, and a lot of it's just lack of education among our colleagues of understanding that while in Cobb County that might not be an issue to you, but there's another 150 plus counties out here that it may be a big issue to, or 130 probably counties that is a big issue to. So I hope we keep, it's kind of like playing football, and of course we get right down the hill down here, we get to see a lot of that. Sometimes it's not necessarily dropping back and throwing the Hail Mary pass to the end zone, scoring the touchdown. It's trying to get those first downs, and that's kind of where I see us at with trying to expand scope. Is we're trying to take a lot of first downs and just inch the ball down the field somewhere.
Well, the state of Georgia owes each of you gentlemen a great thank you for all that you sacrifice to go to the State House. I know you take a lot of hard licks sometimes, but we all know what you do, and on behalf of everybody here, thank you so much for what you do in the State House and for being with us today. Thank you.
Hey, buddy.
Who are you?
Oh, I'm from your insurance company.
How did you get in here?
Listen, don't panic, okay? But she's out of your network now.
I am?
Wait, what?
It's simple. We had to take your doctor out of your network, so now you have to pay her bill.
When did I get dropped from the network?
Wait a minute. If I'm paying her, what am I paying you for?
Okay, get him out of here.
The room.
When insurance companies force doctors out of network, patients pay the bills. Let's end the surprise insurance gap today.
I'm Chip Pettigrew. I'm a career emergency physician. This is my 30th year in Georgia, and it's been a great place to live, great place to raise my kids, and I want to keep it that way for my 7 grandkids. We started the coalition to end the surprise insurance coverage gap because of some economic forces that were causing damage to our patients and forcing them into hard times financially, medical bankruptcies occasionally, and certainly a lot of confusion in what their insurance plans did not cover. This surprise insurance coverage gap was created by insurance companies by creating narrow networks for their own profits, squeezing physicians out by offering them, as we already heard from a panel earlier today, by offering take it or leave it contracts, and oftentimes the contracts aren't enough money to sustain a practice by seeing these patients on. It's not fair for patients to pay high premiums on a monthly basis for individual policies, sometimes as much as a new car payment, or for a family policy, sometimes as much as a household payment, and then find themselves in medical needs situation and seeing that there's a surprise insurance coverage gap, and they're suddenly responsible for the bill. We don't believe that's fair. We think that patients should get fair coverage for the premiums that they're paid, and the providers who are providing care for them should get fair reimbursements for the services that they've offered. In trying to find a solution to this, we've looked at other states and seen that the use of a independent database, which is conflict-free and transparent, is very useful in setting fair reimbursement rates and fair coverage for patients. The best database that's available is totally independent, not-for-profit, conflict-free, and that's Fair Health. Fair Health was an organization that was created out of a RICO lawsuit against large insurance companies, which found that they were criminally involved in manipulating databases to underpay physicians and underpay benefits and force patients to pay balanced bills. Our coalition has engaged the prestigious NORC organization from the University of Chicago to analyze the databases nationally, and we have a report today that is coming out today. And we'd like to talk to you about that and how it will allow for protection of the safety net, which is critically important in rural areas. As you heard today, hospitals and providers are being offered take it or leave it contracts, and that could lead to a critical access problem for healthcare in rural areas. Terry?
Okay. Thank you. I'm Aaron Wazlowski. I'm a Senior Research Director at NORC at the University of Chicago. As Dr. Khan mentioned, NORC is an independent social science research organization affiliated with the University of Chicago. We've been around for 75 years. We do a lot of, originally did a lot of survey work. Now we do a lot of program evaluation work. Much of it for the federal government. I'm actually based in our Washington, D.C. office because a lot of our federal work. Physicians for Fair Coverage asked NORC to take a look at this issue and commission the study based on work that NORC had done several years ago for the Centers for Medicare and Medicaid Services, where we looked at a similar question and that what data sources were most appropriate for use in determining out-of-network reimbursement. So we set to work essentially updating our research from several years ago. There have been some changes in terms of what data are available and how much data are available, and looked at several national data sources as well as state-specific data sources like state all-payer claims databases. So somebody advancing the slides back there. Great, thanks. Oh, perfect. And I have far too many slides, so I'm going to skip through a little bit. Covered this. Just a quick background on our methodology. This was a qualitative study, so it was based on interviews with representatives from the various data sources, as well as a literature review looking at what information are available in the data sources. We ended up speaking with 4 large national data sources and looked at state all-payer claims databases across the country. So we conducted interviews with executives from the data sources and covered issues like the mission and structure of the organization, who's on the board, where does the funding come from. We looked at what data are available and specifically to what extent both allowed and billed charges are available. So not only what the provider charges the payer, but what the payer actually pays in a paid claim. Where the data come from, what kind of quality control and processes are in place, how accessible are the data, including to what extent it's expensive to access the data, and any limitations that the data sources place on the data. So the first, the Healthcare Cost Institute, HCCI, it's a large nonpartisan nonprofit organization. They get data from 4 large national carriers. United, Aetna, Humana, and Kaiser Permanente. They have quite a bit of data, 50 million commercial covered lives and 100 million Medicare covered lives. The data goes back several years. The data are generally used for research purposes, so hypothesis testing. So to the extent government agencies or researchers want to test a hypothesis or do high-level market-level research, the data are licensed for those purposes. So again, there's in terms of looking at the relative strengths and weaknesses of HCCI as a data source for determining out-of-network reimbursement rates, there are a lot of data. It's standard data. The data comes in on an annual basis. A big limitation is that although they do make some data available through a consumer-facing website called Guru, they don't license their larger data set for benchmarking for out-of-network, for benchmarking generally, but specifically for out-of-network reimbursement rates, which is a fairly large limitation, for the purposes of what we were looking at. There are some gaps in the data, although they do have a lot of large payers covered. They don't have any Blue Cross Blue Shield payers. Another issue is that where there are gaps, they don't impute any value. So a gap is a gap. The next organization is Blue Health Intelligence. This is an independent company that was set up by the Blue Cross Blue Shield Association in 2011. They have data from 30 of 36 Blue Cross Blue Shield plans nationally. Their board is made up entirely of Blue Cross Blue Shield plan representatives, although they are an independent company. They have standard data. The data comes in on a monthly basis. Obviously Blue Cross Blue Shield plan enrollment is, represents a large part of enrollment in a lot of states. Skip through here. But the fact that other data, especially Medicare data, are missing, mean that it makes it challenging to sort of make assumptions about what the cost of care is at a local level based just on the Blue Cross Blue Shield data. They also don't license their data for benchmarking purposes. They generally serve their Blue Cross Blue Shield member plans. They do license the data in some circumstances to external entities, but under strict limitations and under strict review by Blue Health Intelligence, and the data are relatively expensive. The next organization is Fair Health. This is the organization that was mentioned earlier, was set up out of New York based on an investigation that occurred into reimbursement practices. It's one of 4 qualified entities that receives Medicare data across the country, which means that, right there is a very large source of data in addition to receiving data from 60 national and regional payers nationally. So they have, fairly broad Medicare and commercial coverage. Standard data. The data comes in some cases on a monthly basis, in some cases quarterly. So this is, generally, based on the Medicare data, both Medicare fee-for-service and Medicare Advantage and commercial data, means that they have, this large number of claims and a very large number of covered lives in their database. They also are already used for, their data are already used to benchmark rates for out-of-network coverage, which is obviously highly relevant to the question that we were looking at. They're used up in New York and Connecticut. A couple of issues with the data are that they don't universally have allowed charges. They have billed charges across the board, but only in about 50% of the cases they have the allowed charge, so the actual paid amount charge. But they do apply scientific algorithms to impute values where there are gaps, either because there are not allowed charges or because they don't have data for a given geographic area. So because they have so much data, they're able to make pretty informed assumptions about what data would look like in the absence of real data. And the final is Truven Market Scan. This is Truven as an IBM company. Truven Market Scan is really a collection of data sets. Truven's sort of been building these data sets going back 30 years. They have a lot of data. Their data generally comes from employers, which means that it's highly proprietary. And there are a lot of restrictions on the use of the data, so they don't generally sort of license it for broad purposes. It's very specific research cases. And their clients, the employers that contribute the data, are obviously very sensitive to how the data are used. Given that it comes from very specific employers, it's a convenient sample. So again, it's hard to make generalizations about the cost of services based on their data, because it's really drilling into specific employers, and specific regions are more represented than others. And I apologize for going so fast. This is a lot. The last sort of general area is state all-payer claims databases. So these are APCDs. Generally, APCDs have sort of started up in the last 15 years or so as a way of supporting state-level payment and delivery system reforms. Basically, they're state-mandated reporting of claims from insurers across the state. There's a lot of variability in terms of what those APCDs look like across states. The requirements look different. How the data are disseminated are different. That sort of thing. A big consideration here is a Supreme Court case last year in which Liberty Mutual health plan out of Vermont challenged the state's ability to mandate reporting of claims for ERISA purposes. Basically, they argued that they were required to report under ERISA already, so that the state was not allowed to sort of add on reporting requirements. The Supreme Court agreed, which means that ERISA plans are now generally exempt from mandates for reporting to state all-payer claims databases. So this has a bigger impact on some states than others. Obviously, some states have more ERISA self-funded plans. If you have a lot of large employers in your state, it means that fewer of those, the claims in that state are going to be subject to an APCD mandate. So again, it makes using use of APCD as a standard source of data for something like setting national benchmarks or state level benchmarks really challenging, because it really depends on what the local kind of considerations are. And this is just a summary of what I already raced through covering. The final slide is just, based on the criteria that, we established, working with Physicians for Fair Coverage and understanding what the kind of needs for developing a benchmark for out-of-network reimbursement rates. Fair Health was the data source that met all of, the most criteria. So, we're talking about a lot of very large data sources, and in some cases, the coverage of one versus another, or accessibility of one or another may be comparable, but Fair Health, in terms of its national coverage and its ability to sort of impute a value where there was not one, and its high level of accessibility through its consumer-facing website, and its kind of relative low cost, and the fact that it's already used for this purpose, meant that those criteria made it sort of the most appropriate source of data for the purpose that we were looking at. So I hope that some of that got through. Again, I probably had about 20 too many slides. I apologize for that, but I'll hand it over to Michelle.